If you wake up tired, crave carbs, and your blood pressure is creeping up, this might not be aging. It might be your airway. Because you can do everything right, protein, steps, supplements, sleep hygiene, and still wake up feeling like you fought a bear in your sleep. Today we're talking sleep apnea, the undiagnosed reason a lot of healthy people feel exhausted, foggy, and stuck. And by the end, you'll be able to spot your risk in about 3 minutes, know what to ask your doctor, and understand what actually helps. First, the myth that keeps this hidden. Snoring can be harmless. But obstructive sleep apnea is repeated airway collapse that drops oxygen and spikes stress hormones, sometimes dozens of times per hour, while your brain does tiny, micro wake-ups to reopen the airway. You don't remember it, you just wake up wrecked. And here's the twist. Sleep apnea doesn't only happen to older, obese men. You can be lean and athletic and still have an airway that collapses when your muscles relax. You can also have sleep apnea with minimal snoring, including quiet apnea patterns, and in many women who present differently. So, I don't snore is not a diagnosis. It's a guess. Why does this matter for longevity? Because every breathing pause is a stress event. Airway closes, oxygen dips, CO2 rises, adrenaline spikes, you partially wake, airway opens again. Repeat all night. It's like your nervous system is pulling the fire alarm, in 30-second intervals, for years. Over time, this shows up as the stuff people call getting older. Blood pressure creeping up, mood and patience getting worse, brain fog, cravings that feel weirdly aggressive for someone who eats clean. And one of the most overlooked clues is nighttime blood pressure. You're supposed to dip during sleep, but sleep apnea can blunt that dip or even push pressures higher at night. So you can look fine in a daytime office reading and still be getting beat up at night. What does sleep apnea feel like in real life? Classic signs are loud snoring, witnessed pauses or gasping, morning headaches, dry mouth, and unrefreshing sleep. But a lot of people don't feel sleepy. They feel tired, wired, and irritable. They feel scattered, like their brain has 27 tabs open. And here's a surprising one. Getting up to pee at night. Nocturia can be a sleep apnea clue because breathing against a closed airway creates pressure swings that can increase urine production, plus you're waking anyway. Important nuance for women. Women are more likely to show insomnia, fatigue, mood symptoms, and non-restorative sleep rather than the stereotypical loud snoring story. That's one reason they get missed. So if you've been told, it's stress, it's menopause, or it's just life, keep listening. Now for the 3-minute risk screen. This is not a diagnosis. It's triage. Use the stop-bang questions. Snore loudly, tired daytime fatigue, observed apneas or gasping, pressure, high blood pressure. Then bang, BMI high, age over 50, neck circumference large, and male sex. Each yes is 1 point. Higher scores mean a higher probability of moderate to severe sleep apnea. Use it to decide whether to escalate, not to label yourself. Red flags where you skip the quiz and talk to a clinician. Witnessed breathing pauses or choking, gasping. Excessive sleepiness where driving feels risky. Resistant or unexplained hypertension, especially if nighttime readings are high. Or atrial fibrillation or recurrent arrhythmias plus snoring and fatigue patterns. Those are get assessed problems. Quick credibility moment. The U.S. Preventive Services Task Force says evidence is insufficient to recommend for or against screening asymptomatic adults. That doesn't mean don't evaluate. It means routine screening of people without recognized symptoms isn't settled. If you have symptoms, you're not the asymptomatic screening group. Okay, testing. The gold standard is an in-lab polysomnography. That's the full sensor setup, brain waves, airflow, breathing effort, oxygen, limb movements. It's best when the case is complex, or when home testing might miss things. The other option is the Home Sleep Apnea Test, HSAT. It can work well for uncomplicated adults with a high suspicion of moderate to severe OSA. But HSAT usually doesn't measure brain waves, so it can underestimate severity in some people. Key rule: If an HSAT is negative or inconclusive but suspicion remains, the next step is often an in-lab study. And another key rule: questionnaires alone should not be used to diagnose sleep apnea without sleep testing. When you get results, you'll hear about AHI, events per hour. Mild is usually 5 to 14, moderate 15 to 29, severe 30 plus. But here's the nuance: AHI is not the whole story. Two people can have the same AHI and very different oxygen drops. So ask about oxygen desaturation patterns too, sometimes summarized as oxygen burden. Now the treatment ladder, where fear turns into relief. Because sleep apnea is one of the most fixable high-impact problems in modern health. Step 1. Foundations. If your apnea is worse on your back, positional therapy and side sleeping can help. Reduce alcohol and sedatives at night, because they relax airway tone. Treat nasal congestion and allergies so you can breathe through your nose. And if excess weight is part of your picture, weight loss plus resistance training and cardio can reduce severity and improve symptoms. Step 2. CPAP or APAP, the first-line device. Think of it as an air splint that keeps the airway open. For many people, it's the fastest route to, "I forgot what normal energy feels like." Yes, it takes adjustment. But so does living with nightly oxygen dips and adrenaline spikes. The honest science on blood pressure. On average, CPAP tends to lower blood pressure modestly, often around 2 to 3 mm of mercury, with bigger effects in some groups like resistant hypertension. It can also improve nighttime non-dipping, which matters for long-term risk. And here's a benefit people feel immediately: safety. Sleep apnea increases crash risk. Treating OSA with CPAP is associated with a large reduction in crash risk in systematic reviews and meta-analyses. If you've ever felt drowsy behind the wheel, take this seriously. Step 3. Oral appliances. A mandibular advancement device moves the jaw forward to keep the airway open. Often used for mild to moderate OSA, or if CPAP isn't tolerable. The best treatment is the one you'll actually use. Step 4. Specialist options. Hypoglossal nerve stimulation and certain surgeries can help selected patients, depending on anatomy and severity. That's a conversation for a sleep specialist, not TikTok. Step 5. The new era for a specific subgroup. In late 2024, the FDA approved tirzepatide, Zepbound, for moderate to severe OSA in adults with obesity, alongside diet and activity. This is not a medication for every case of sleep apnea. It targets weight-related mechanisms, and anatomy still matters. Now the contrarian truth. Observational data strongly links sleep apnea with cardiovascular risk. But big randomized trials of CPAP in some cardiovascular populations often didn't show large reductions in major events in intention to treat analyses. The common reason is adherence. CPAP doesn't work if it's on your nightstand. When analyses focus on people who actually use CPAP, often defined as 4 or more hours per night, signals of cardiovascular benefit appear. So the game is making treatment usable: mask fitting, humidification, nasal support, and follow-up. Here's what to ask your doctor. My symptoms fit possible OSA. Should I do HSAT or an in-lab study? If HSAT is negative but I still have symptoms, can we do polysomnography? Do I have factors that make HSAT less appropriate, like severe insomnia, significant heart, lung disease, neuromuscular issues, opioids, or a history of stroke? If positive, what's my severity and what did my oxygen look like? What's the best starting therapy for me, and how will we support adherence? One last safety note: if you're so sleepy that driving feels risky, don't power through. Treating sleep apnea can change your life. Falling asleep at the wheel can end it. If this helped, we'd love it if you'd hit like and subscribe. Please check the description for the tools that match today's topic and our Longevity Compass Amazon KDP book. And remember the core takeaway: if you wake up tired, crave carbs, and your blood pressure is creeping up, it might not be aging. It might be your airway, and it's one of the most fixable problems in modern health.